Welcome to AETCM, the emergency medicine channel.
Yeah, please.
A 25-year-old male presented to the ER with complaints of acute onset breathlessness since one day. On our initial 10-second assessment, the patient was conscious, oriented, and obeying commands. Coming to airway was patent, no secretions. Coming to breathing, a respiratory rate of 30 breaths per minute, saturation of 86% in room air with bilateral V's.
Okay.
At this point of time, we kept the patient in propped up position and started the patient on oxygen via face mask of 7 liters and also started nebulizations. Coming to circulation, BP of 120 bar 80 millimeters of mercury, pulse rate of 100 per minute. 2 large bore IV cannulas were inserted during this point of time and blood samples were taken. Coming to disability, GCS of E4, V5, M6, pupil bilaterally equally reacting to light. Coming to exposure, temperature of 98.2 degree Fahrenheit with a GRBS of 125 milligram per deciliter. Coming to adjuncts of primary survey, ABG was taken showing a pH of 7.406, PCO2 of 38, bicarb of 25 and PO2 of 53. CBC CRP point of care was taken. SO2 was 85, sir.
Okay. 85.
Yes, sir.
Okay, what was the monitor saturation during that time?
Sir, without O2 we took the ABG, sir. And then the motor saturation was like 85 that.
85. Yes. So feel it's an arterial blood gas only. Okay.
Coming to, we taken an ECG at this point of time showing sinus tachycardia, sir. CBC CRP point of care was also taken showing a total count of 11,000 with a CRP of 16, sir.
So you want to summarize at this point?
Sir, a 25-year-old male presented ER with acute onset breathlessness with on examination wise showing bilateral V's and on ABG showing type 1 respiratory failure. Probably one LRTA that has flared up an airway disease.
Why LRTA? Like any symptoms suggestive of LRTA or?
So counts were on the higher side, 11,000.
Not that, and even CRP was like borderline,
16.
Okay. I mean, cannot rule out, but definitely other causes also needs to be kept in mind, right? Okay. Any other accessory muscles were used? Or?
At this point of time, no,
you didn't feel that. No, so he was just tachypneic, but no use of accessory muscles. But primary hypoxemia is there, and you have started the patient on O2. Okay. How will you say it is an ABG versus VBG?
We have to compare the SO2 with the corresponding saturation in the pulse oximeters.
Can you get a very high PaO2 in a VBG also? Say the PaO2 came as 100. SO2 is 80 or 90. Can it still be a VBG? It can. Okay. Once you are hyperoxygenating the patient, what you are going to see in a VBG can be a reflection of that oxygen. Okay. So a high PaO2 in the VBG can be present in a VBG when the patient is on a very high flow oxygen. Okay. So we usually have this habit, if you are not sure whether it's an arterial or a venous sample, we will send the sample, right? Even in that, you might end up with a higher PO2. So remember that always. Okay. Because it is a proportion of what is found in the arterial. Right? Okay. So here definitely you have compared the saturation and the SO2 in the blood gas, which is looking in the similar range. So definitely it is an ABG and there is primary hypoxemia. Fine. Anything else? What else are you interested in the ABG in such a patient?
PO2, sir.
PO2 is we told. Anything else?
PCO2, bicarb and pH.
Okay. PCO2 specifically?
Whether to differentiate between a type 1 and a type 2 respiratory failure.
Okay. And so what happens in such patients? Are you more concerned about a PCO2 washout or retention?
PCO2 retention, sir.
Why?
There can be a respiratory component also, respiratory acidosis. So we need to explain whether there is a parenchymal involvement also.
Not necessarily, no. Especially what happens in acute severe asthma. So in the initial phases, the patient is going to hyperventilate and there will be a respiratory washout, right? So, but in due course, what happens? There will be respiratory muscle fatigue. Okay, that is when your PCO2 retention can happen. So even though traditionally we say that PCO2 retention is associated with COPD, if you are having a patient with bronchial asthma coming with CO2 retention, we are looking at deep trouble. So basically, patient has exhausted his reserves and is in an impending respiratory arrest state. Okay, fine. So that is the next thing. PCO2 can be either low or high. We are going to be more worried if the PCO2 is high. Okay, fine. Anything else?
No, sir.
Again, hypoxemia is there. So another thing will be lactate, right? What is the lactate?
It was normal, sir.
Normal. Okay, fine. Continue.
Coming to sample history, 25-year-old male presented to the ER with complaints of acute onset breathlessness since 1 day. The patient says that the symptoms started since Diwali after the patient inhaled the smokes from the firecrackers. Breathlessness was gradual, progressive with an MMRC which started from initially 0 and now progressed to 4, sir. Associated fever was also present, sir. No history of any orthopnea, PND, no chest pain. No productive cough, no other associated symptoms, sir.
Okay.
No other aggravating or relieving factors were present.
Okay.
Coming to past history, the patient was a known case of bronchial asthma on Astalin MDI SOS, sir.
Once you hear that somebody is a known asthmatic, okay, what are the important histories you are going to take? Because we need to know about the severity of asthma, right? So what are the questions you will ask?
One, we have to find out the triggering factor, sir.
Okay.
That has led to the present situation. Then the frequency of exacerbations.
Okay.
Whether the patient comes under the classification, whether it's a mild, moderate, or a severe asthma. Sir.
Okay. So what is usually a good control asthma? Remember? So one is the frequency of use of inhalers. Okay. If it is less than 2 uses in 1 week, acute use in 1 week, okay, then that is one thing. The patient wakes up at night, that is nocturnal awakening because of breathing difficulty. If those episodes are less in a month, less than 2 in a month, that again is an indicator, right? Third will be use of need for corticosteroids, oral corticosteroids again. That should not be there ideally, right? And fourth will be frequent admission because of acute severe asthma. So these are the 4 things which should not be there to say that the asthma is under good control. So any of these things are going to come in, then definitely the patient is in a severe or a severe asthma kind of pattern. So these are the 4 things. One is the frequency of use, nocturnal symptoms, use of corticosteroids, and next will be admission. Okay, continue.
Coming to past history.
So here, how was it? Like, what was the frequency of his use of inhalers?
The patient had only 1 episode of exacerbation, sir, in the past 6 months, sir.
Okay.
That's why
and is he on a frequent inhaler use?
No, SOS, sir.
SOS. And any known triggers?
For patient, smoke was the trigger, sir, in this condition.
Okay. What are the usual triggers?
One can be, most common is dust, sir.
Okay, very good.
And then smoke can be another thing. And
what's the most commonest trigger? The seasonal. Okay, change in seasons is usually the most common thing. Second thing, as you told, is dust, smoke, insects, cockroaches, things like that. Just this molds, especially during monsoon and all, there is increased chance of wet surfaces and molds and things like that can happen. No? So those things. Okay. Infections, very good. Certain drugs. Okay, especially beta blockers, ACE inhibitors, NSAIDs, aspirin, those kind of things are known to cause, right? So any new medications when the patient is started, always look for whether that has a potential to act as a trigger. Okay, fine. So none of those things were here. Within last 6 months, there's one admission, and he was reasonable control with just inhalational bronchodilators, right? Yes. Okay, continue.
Coming to past history, no history of drug history. The patient was on Astalin MDI SOS, sir. No other drug history. The personal history, the patient is a known case of smoker, sir.
Okay.
The last meal was taken around 6 p.m., sir.
So he's actively smoking even now?
Yes, sir.
Fine.
Coming to examination, general examination, no pallor, no icterus, cyanosis, clubbing, generalized lymphadenopathy or pedal edema. Coming to systemic examination, respiratory system, the patient was tachypnic, but no use of any accessory muscles. On examination wise, there was bilateral wheeze that was present. Other systems were within normal limits. So the initial impression was an acute infective exacerbation of bronchial asthma with the patient in type 1 respiratory failure, sir.
Okay, fine. So if you are putting the trigger as exposure to cracker smoke, then definitely infection being the cause will come down the line, right? So you have a chemical trigger or mechanical trigger kind of scenario, right? So yeah, both can coexist, but always like less likely to be infective if there is this thing within one day. So okay, so that will be one thing definitely we need to keep in mind. Okay, continue.
Then initially in this patient, we have kept the patient in propped up position.
Okay.
Then
So
we
you are now talking about the management part, right? Okay. Any role for X-ray in acute severe asthma management? Is it must to get an X-ray, or if at all we get an X-ray, what is the objective of getting an X-ray?
It is proven.
Basically, a known case of bronchial asthma, acute exacerbation, the role of X-rays are limited, right? We are going to look for specific answers when we are going for an X-ray, right? If there is any secondary infection, definitely probably an X-ray might be helpful. If you are suspecting a component of cardiac failure, okay, probably X-ray might have some role, right? If we are expecting some kind of pneumothorax or secondary complications, those are the situations where X-ray can come in handy. Otherwise, in a routine acute exacerbation of acute severe asthma or acute exacerbation of asthma, X-ray might be normal or negative, right? Okay, fine.
So in this patient, we keep the patient initially in the propped up position, sir. We started the patient on oxygen 8 liters by face mask, sir. Then we also started nebulization, sir. We have started Diolin, that is salbutamol 2.5 milligram plus ipratropium bromide 500 milligram, 3 cycles 20 minutes apart, sir.
Okay. So what is the recommendation for acute severe asthma? How will you usually start? Is it a combination or?
Sir,
If you go by the guidelines, how is it?
Initially, we can start on nebulization, sir.
Of?
Salbutamol, sir. Short-acting beta
So you
agonist.
start with salbutamol dose
2.5 to 5
mg.
Every 20 minutes apart, 3 cycles we can.
Okay, okay. So practically what you can do is that you can interchange. So you give the first cycle of salbutamol, as he told 5 mg nebulization, that will take close to 10 to 15. The standard nebulizers which we use, it will deliver over 10 to 15 minutes. Okay. After that, you give the next dose of ipratropium. And then, so that this will kind of, the patient will get at least 3 doses of both salbutamol and ipratropium. Ipratropium, what's the dose?
500.
500, good. So this, by the end of 1 hour, the patient would have got one dose of each. By that time, if you're not getting control, that is the time when you're going for the second line. Okay. So now we have given this. Then what is the follow-up doses of salbutamol? So after your initial 3 doses, you can repeat it every 1 to 4th hourly. So if it is severe asthma, you feel the symptoms are not yet under control, you can repeat it every hourly for the next 4 doses. If it is reasonably under control, you can write an order for Q4th hourly. Likewise with ipratropium, every hourly to 3rd hourly. You can repeat initially. Every hourly for the first 3 hours. Okay. Now you have given that. Patient is not adequately controlled. What will be the second line?
We can give IV steroids, sir.
Okay.
We can give IV hydrocortisone 100 mg, IV stat.
Dose is ideally in adults if you're giving hydrocortisone, you need a higher dose. 150 to 200 is the recommended dose of hydrocortisone. There is some kind of preference for methylprednisolone usually, 125 mg, 60 to 125 mg of methylprednisolone. But at the same time, you can use any steroid at the end of the day. If you have Dexa can also be given. Usually 6 to 10 mg of IV Dexa can also be used. So any of the steroids, IV, with the proper dosing. Okay, fine. Then now we have given IV steroids also. If you have oral steroids, prednisolone again can be. If you don't have IV, prednisolone 60 mg will be a recent kind of a dose. Okay, fine. Now you have given inhalers and you have given steroids. What next? Still the patient is symptomatic.
We can try magnesium sulfate.
Very good. What's the dose?
2 gram in 100 ml over 20 minutes.
Okay, fine. Now we have tried magnesium sulfate also. Now suppose the patient is not better with magnesium sulfate. What next?
Try for NIV, sir.
Okay, so simultaneously you are starting the patient on NIV. In acute severe asthma, if you ask for evidence, there is not much of evidence in NIV, but most of the centers we give a trial of NIV. Okay, trial of NIV, which could be either a BiPAP or a CPAP based upon the patient comfort. Okay, fine. Especially when hypoxemia is there, probably to buy some time, you might find some role of NIV. Okay, you have started on NIV also. Still the patient is not better.
Then we need to plan for mechanical.
Okay, there are certain salvage measures before intubation. What are they? You can try with
HFNC.
IM adrenal. Okay. So before intubation, definitely if the patient has reasonable hemodynamics and you feel there is a window of attempting adrenaline, definitely you can give 0.3 to 0.5 mg of 1:2000 adrenaline IM. Okay, especially when you have some kind of allergic trigger and things like that. Okay, alternative will be terbutaline, but we can definitely go with subcutaneous dose of terbutaline, but we can try IEM adrenaline, one dose, or even a repeat dose after 20 minutes max. Okay, if that is also not working, that is the time when we are going to consider regarding intubation. Okay, now coming to intubation in acute severe asthma, please.
So the drugs we can use like Midacetamide and Rocuronium can.
Okay, before that, any regarding pre-oxygenation and all.
We can try usually NRBM 15 liters.
Okay, very good.
3 to 5.
Or HFNC. Okay, fine. And even bagging, you have to be careful. You are not going for excessive kind of hyperventilating kind of scenario. It's still gentle bagging with a good inspiratory hold, right? Okay, then
comes the drugs. We
okay.
can give.
You are going for RSI, right? Fine. What are the drugs? What is the choice of drugs?
Midacetamide and Rocuronium.
Here again, ketamine has a kind of a slight superiority among the induction agents because of its bronchodilatory effect. Okay, so among the agents, if there is no other contraindications, definitely you can go with ketamine. Okay, and even propofol theoretically has some bronchodilatory effect, but can cause hypotension and all. So we usually stick with ketamine along with a sedative agent and rocuronium. Okay, okay. So that is the induction agent of choice in acute severe asthma. Right. Then post intubation.
We need to keep the FiO2 initially on the higher side. So then PO2 since we are expecting a type.
What are our target saturations?
PaO2 has to be increased to reduce the type 1 respiratory failure.
Generally, you can be happy with a saturation of about 92% in an adult, and in a pregnant lady around about 95. That will be the usual target saturations. Okay, we can accept a bit of hypercarbia in the initial phases. Okay, but definitely it should be above 92% is all we are looking at that point. Okay, fine. Then with a lower tidal volume, with a lower rate, the initial setting will be something like tidal volume of around 6 to 8 ml per kg, with a respiratory rate of around 12. Okay, and with a target mid ventilation of around maybe 110 ml per kg kind of setting with a PEEP of around 5. That will be kind of a starting setting for bronchial asthma, acute exacerbation with severe bronchospasm kind of scenario. Okay, after that you have to go on with titrating of the ventilatory settings based upon the blood gas findings. Major concern is
PCO2.
Yeah. One is to wash out the PCO2, but there is something called as auto PEEP. Right? What is auto PEEP?
It is the positive pressure that is present in the alveoli at the end of exhalations. That's a complication of mechanical ventilation.
You have the usual PEEP. Now, what happens in asthma exacerbation is basically the air gets trapped, right? There will be breath stacking. So there is an intrinsic PEEP also being generated. So the ventilator is giving a PEEP, and within the patient, because of the breath stacking, there is an additional intrinsic PEEP also. Now what happens? Again, further hyperinflation happens. This can either further lead to further hemodynamic compromise, right?
Hypotension,
venous return decreases, your intrathoracic pressure is going up. So that is a complication which you have to anticipate while you are intubated a bronchial asthma kind of patient. You have intubated the patient, after some time you are seeing that the patient is going into hypotension, desaturation. Okay, there you have to identify. Usually what you need to do is that you have to calculate the plateau pressures. Okay, so with an inspiratory hold, you calculate the plateau pressures. P-plat ideally should be less than 30. If the P-plat is more than 30, that again is indicative of an auto PEEP or dynamic hyperventilation. Okay, once you detect that, there are measures in which you have to overcome that. Okay, either you can go up on total intrinsic PEEP, once you total peak pressures, at least around 80 you go up on the PEEP which you are keeping. Or else if the patient is
Increase
significantly,
expiratory time.
exactly. So once you detect it and the patient is in hypotensive, even disconnecting a ventilator for a transient period of time will kind of help in bringing down the intrinsic PEEP. Okay. So this is a complication which you need to at least be aware of and to detect once you connect the patient to a ventilator. Okay, fine. Then continue. In our patient?
In our patient, later we shifted the patient to HFNC, sir.
Okay.
And 24 hours.
Now, how is HFNC going to help?
HFNC,
What does it have which the other oxygen delivery devices are not going to have?
the flow rate, sir.
Okay.
Humidified oxygen can be transferred.
Okay.
So the higher flow rate can be given.
Okay.
60 lit up to 60 liter per minute.
Yeah.
With an FiO2 ranging from approximately 21 to 100.
So basically, your flow rate is going to act as a small PEEP also. Okay, something like 60 liters of flow, approximately 5 to 6 of PEEP also it's going to generate. Okay, so the alveolar collapse is being prevented again. Right. Then, so here we kept the patient on HFNC and then
Later we started nebulizations, continued with HFNC, we taken routine ABGs, and by 24 to 48 hours the patient was tolerating HFNC. Gradually we tapered down the FiO2, then we tapered down the flow rate, and once the target has been achieved, we shifted the patient from HFNC to nasal cannula, so no flow nasal cannula.
okay.
And the patient was also tolerating nasal cannula. Once everything subsided, and then kept the patient in room air. Patient was tolerating room air.
Okay. Is there any superiority of nebulizations over MDI in a conscious oriented patient?
No, sir. No. If the patient is severely tachypneic, not able to tolerate.
In a patient who is hemodynamically stable, conscious oriented, even a puff of MDA is good enough. Usually, what we told as or 5 mg of salbutamol, you can give 4 to 8 puffs. Okay, fine. So here we have asked him to continue on the bronchodilators after discharge. But more important is he has to stop smoking. Okay, if he is, the trigger is with the smoke, definitely he needs to be sent to a smoking cessation clinic and get the habit reduced. Otherwise, there is no point in continuing the treatment. Okay, fine. Anything else? You want to add anything on bronchial asthma? Any other management principles? Any long-term management? Anything?
So basically, we divide bronchial asthma as in new era as eosinophilic and neutrophilic bronchial asthma.
Okay.
Eosinophilic bronchial asthma is mediated by the type 2 and TH2, and the neutrophilic is mediated by the TH17. The precursor agent is the thymic stromal lymphopoietic precursor.
Okay.
That will activate on TH2 and TH17 and help in the release of interleukin 5 and interleukin 17 correspondingly and causes eosinophilic and neutrophilic. This is important that because new drugs like thymic stromal lymphocyte precursor inhibitors are there, nepolizumab, that will inhibit the initial event itself.
Okay.
And we have other agents like interleukin 5 inhibitors, interleukin 17 inhibitors. These target points we will specifically mediated drugs. Then coming to the classifications of asthma, we will classify as intermediate, mild, moderate, severe, and asthma in impending respiratory failure.
Okay.
In the emergency settings, our duty to differentiate whether the patient is having a severe asthma or an asthma in impending respiratory failure.
Okay.
Based on the inspection, we can see if the patient is using the accessory muscles of respiration, the patient is dyspneic, the patient is agitated, that point towards an acute severe asthma. Whereas impending respiratory failure, the patient will be mute, there will be altered sensorium, and there will be paradoxical breathing also will be there. Coming to vitals, usually in acute severe asthma, there will be tachycardia, whereas in impending respiratory arrest, the patient will have a relative bradycardia.
Okay.
And coming to the examination wise, also the patient will have bilateral coarse wheeze will be there in the case of acute severe asthma, whereas there will be silent chest in the case of impending respiratory failure.
Okay. Okay. Right. Thank you.